have the last talk of this IC. Dr. Rosemary Tomy, she is a senior consultant at Ahilya Eye Hospital, Patambi, and she'll be talking on from bells to brainstem, tracing the facial nerve.
Very good morning, everyone. At the outset, I would like to thank Ramya for having me here. Now, after all these heavy brainstorming sessions, mine is going to be a very basic session. Bells to brainstem, tracing the facial nerve. Now, I'll just be briefing you what to do when you see a facial nerve in your OPD. Now, this is a muscle that affects facial communication expression so much. And if you look at the umpteen number of celebrities that have taken to social media, how they have overcome their facial nerve palsy trauma, we see how it affects irrespective of gender, age, social strata. Facial nerve is always something every ophthalmic subspecialty has to manage. So ultimately, what do we want to diagnose? We want it to be diagnosed as, if it is Bell's palsy, we are happy. No imaging, no treatment, most of the patients are going to improve. Now, you all know Bell's palsy is a total unilateral lower motor neuron lesion with a classical drooping eyebrow, drooping eyelid, flattening of nasolabial fold, drooping corner of the mouth. But to diagnose that it is only Bell's palsy and not to worry, we have to rule out all other causes of facial nerve palsy, and ultimately we need to know the neuroanatomy of it. So, how does the video work? Okay. So I'll just brief you through. I'm sorry, PGs are not here. This is a facial nerve nucleus that is present in the lower part of the pons. You have the 6 nerve nucleus adjacent to it. Facial nerve fibers pass posteriorly and exit through the pontomedullary junction. Pontomedullary junction is a very busy place. You have the 8th nerve, everything, but I'm just explaining facial nerve. Facial nerve has a superior salivatory nucleus adjacent to it, which gives off lacrimatory and salivatory fibers. And the next component of facial nerve will be sensory fibers from the anterior 2/3 of the tongue. Sensory fibers, they get connected to the nucleus tractus solitarius. And there is a 4th component of facial nerve, general somatic afferent from the external ear, which also project to the spinal nucleus of trigeminal nerve. All pain, touch, temperature, everything is connected with trigeminal nerve. So facial nerve, 4 components: motor nucleus proper, then you have superior salivatory parasympathetic fibers, sensory fibers, we have the taste and external ear sensations. Now, classically they say there are 2 roots. You have a motor root, you have a sensory root. Sensory root, they call it the nervus intermedius, but when we look at the nervus intermedius, all those 3 roots, what we need to understand is there is a parasympathetic fiber within that sensory root. Okay, so this is what we have just seen. Now we'll go to the proper course of the facial nerve. Now, from the pons, okay, I'll go to the next slide. Okay, so from the pons, all fibers go into, I think the video is not working, all the fibers go into the internal auditory meatus and till genu here, till the genu here, they all pass together. And from the genu here, the story starts changing. So first we'll be describing the facial nerve proper. Facial nerve branchiomotor fibers, those go inside the facial canal. Midway, it gives off the nerve to the stapedius. Now this is very important because when you have a loud noise, the controls the movement of the stapes so that the noise is dampened. So what will happen in facial nerve palsy at this juncture? When the nerve to stapedius is impaired, a loud noise is going to cause hyperacusis to the patient. So that is the first branch of facial nerve. Then it goes downwards, exits out of the stylomastoid foramen, gives off a posterior auricular branch, then 2 branches, nerve to digastric and nerve to posterior highlight, and then it enters the parotid gland and gives off the classical, temporal, zygomatic, buccal, marginal mandibular, cervical branches, which we all know. So that will be the motor root of facial nerve. Next, we have covered the motor root. So next we'll see, okay. So to explain the next, we know that I'll just explain the exits. In this diagram, this will be the foramen ovale, foramen lacerum, foramen rotundum, and I've marked the pterygopalatine fossa there. Now I'm going to explain what is going to happen to the lacrimatory fibers. We have seen motor root, now we are going to see the parasympathetic fibers. Lacrimatory fibers from the pons have to reach the lacrimal gland in the orbit there. So all fibers, they pass together in the internal auditory meatus till the geniculate ganglion. So lacrimatory fibers pass into the geniculate ganglion, and from the geniculate ganglion, again I think the video is not playing. It's not working. Okay, now it's coming. Okay, so the lacrimatory fibers, they reach from the genu, and from the genu, these lacrimatory fibers move into the middle cranial fossa, and from the middle cranial fossa, they pass into the foramen lacerum, and from the foramen lacerum, they meet a friend there, the internal carotid artery with the sympathetic plexus there. Sympathetic plexus give off a sympathetic nerve, and these two pass together. Now, for some names, those lacrimatory fibers are known as the greater petrosal nerve, while the sympathetic fibers from internal carotid is the deeper petrosal nerve, and together when they pass, they are known as the Vidian nerve. Now, this Vidian nerve synapses in the pterygopalatine ganglion. Now, to understand what happens further, we need to update ourselves with the trigeminal ganglion that is present there. Trigeminal ganglion, we all know, gives 3 branches. Ophthalmic, maxillary, mandibular. Ophthalmic branch, we all know, it enters the superior orbital fissure, gives off the nasociliary, frontal, lacrimal branches. Lacrimal branches supplies the lacrimal gland, that we all know. Then, the maxillary branch goes into the pterygopalatine fossa, gives out the zygomatic branch. Now, what happens? The postganglionic fibers from the pterygopalatine ganglion jumps to the zygomatic nerve, jumps to the lacrimal nerve, and innervates the lacrimal gland. So, that is the pathway of lacrimatory fibers. So, now we have seen motor route, we have seen parasympathetic lacrimatory route. Now for the next one. Okay, now we are seeing the salivatory fibers. Salivatory fibers again, okay, this is again repeat. Okay, now for the next, okay, so we have seen the ophthalmic, we have seen the maxillary, and for the mandibular branch comes down, it gives us the lingual nerve. Lingual nerve is responsible for touch pain temperature, anterior 2/3 of the tongue. Now we are going to see the salivatory fibers that have to reach the submandibular sublingual glands. Okay, so the salivatory fibers, again, they pass through internal auditory meatus till they reach the genu. They pass along with the fibers of the facial nerve, proper motor fibers. Halfway through, they realize they have to reach the submandibular gland. So from there, they jump into the middle ear cavity, exit through the petrotympanic fissure, and go along with the lingual nerve. And here on the path, they synapse with the submandibular ganglion. And postganglionic fibers from the submandibular ganglion innervate the submandibular and sublingual glands. So that is a salivatory pathway. So we are done with motor route, we are done with the parasympathetic fibers. So next we need to understand the sensory fibers. Sensory fibers from anterior 2/3 of the tongue here, again they pass along with these fibers that you have just described. They enter into the facial canal, pass the geniculate ganglion which have cell bodies of the taste fibers, and they reach the nucleus tractus solitarius. Clear? Now the last component will be the general somatic afferent fibers from the ear. Here, from the ear, these general somatic afferent fibers pass along with the posterior auricular nerve, the first branch of the facial nerve proper, enter into the facial canal. They have cell bodies in the geniculate ganglion, and they are projected to the spinal nucleus of the trigeminal nerve. So once this network is clear to us, now we have seen what happens to the motor route, we have seen what happens to the parasympathetic fibers, sensory and general somatic afferent. Once this is clear, localization of facial nerve is very clear. Now if you look at the second chart, start from bottom, extracranial. So any lesion here is going to affect the facial nerve muscles on one side only. When the lesion appears above to this tympanomastoid, once the lesion is here, what happens? Nerve to the stapes is going to be affected. You are going to get a hyperacusis. Your salivation is going to be decreased because the salivatory fibers are affected and the facial muscles are affected. Taste is also affected. When you have a lesion at the level of the geniculate ganglion here, what happens? Your lacrimatory fibers are affected, so lacrimation is going to be disturbed. So that will help you in localization once you know the anatomy. And of course, once the nucleus is reached, cerebellopontine angle, you have 8th nerve involvement along with it. Nuclear level, again, we have had detailed discussion on what will happen at the pons. Supranuclear, we all know this chart. Both sides of the cerebrum innervate the upper part of the face. Lower part of the face is innervated only by the contralateral. So when you have a cerebral lesion here, a stroke or multiple, something is happening at the cerebral cortex here, the upper face is going to be spared while the contralateral lower part only is going to be affected. So that is how we differentiate between UMN and LMN lesions. Now all those celebrities I showed you in the beginning, we'll see what happened to them. Bell's palsy is very common. Almost all 70% of facial nerve palsies are Bell's palsies. Usually they have a viral prodromal history. The current hypothesis, that is all we can say, It is said to be due to herpes simplex virus etiology. Why? Because we have seen the tight facial canal in which the facial nerve passes. It is too tight. When you have an edema, inflammation there, the nerve doesn't have space to distend. There is ischemia and there is impairment of the functional nerve function there, and you get a facial nerve palsy. Usually, imaging is not needed when it is a classical Bell's palsy, especially in age groups 15 to 50. But anything outside that, and when this presents, it's usually complete within 20 to 48 hours. So you have a long-standing facial palsy, you have atypical age group, you don't have resolution. Almost 50% of these cases are going to resolve in 6 months, and 85 to 90% are going to resolve in 1 year. So if it doesn't, then you have to look for something atypical. As ophthalmologists, during this tenure, what we have to see is we just have to ensure the patient has had proper eye care to prevent exposure keratitis. So even if you don't treat, these patients might improve. Angelina Jolie finally accredited her improvement to Chinese acupuncture, while Anupam Kher just said that he kept away from films and it improved. But if you see the patient within 72 hours of onset, give oral prednisolone in this dosage. Antivirals are generally not study-wise recommended, but some people give them anyway. Second will be trauma. When you look in the case of this young lady, when Taliban shot her, she had an injury to the petrous part of temporal. Now, all these structures we see were in the temporal bone. So, initially, she went a surgical exploration, but then it was persisting, and many years later, 2 years later, they undertook her for nerve grafting, and you can see the final result is not so bad. It can also be due to iatrogenic, CP angle tumors dissection, autologic surgeries can listen. What we have to rule out is this: infection. Justin Bieber took to social media how he developed Ramsay-Hunt syndrome. So always look for pain. Always look for vesicles in outer ear, because if this is the case, you have to treat the patient with steroids, analgesia, and full dose acyclovir or valacyclovir. Because if you don't treat this, almost 12% it is going to not, only 12% will recover, but if you treat with this conundrum, more than 50 to 70% recovery will be achieved. Then other infections, acute otitis media, mastoiditis, Lyme disease to be ruled out. Slowly progressing facial nerve palsies, rule out malignancies. Again, another indication for imaging. Facial nerve palsy can occur in children also. Rocky Fame, we are all, we look at his facial nerve palsy, but that was something he achieved by birth, due to forceps delivery. Then syndromic, genetic are all there. George Clooney, everyone speaks about his cute smile, but that was due to an acquired 15 years age when he developed a facial palsy. And last slide, bilateral facial palsy is almost never idiopathic. You always have to look for a systemic cause. Lyme disease, Guillain-Barré, diabetes, sarcoidosis, all have to be ruled out. So I hope facial nerve palsy, if it is Bell's palsy, you are safe, patient is safe, but rule out all other causes. Thank you.
Thank you so much, ma'am. You literally took us through our MBBS days. It was very nice presentation. Thank you.